Hello everyone and welcome to our module on STEMI. STEMI stands for ST elevation myocardial infarction. It's a type of myocardial infarction where patients have angina at rest and the ST segments are elevated on the EKG. Let's look at this EKG on the screen here. This is the baseline where the P wave occurs, and this is the ST segment here after the QRS complex, and you can see that it's elevated above the baseline. So if a patient had chest pain and these EKG findings, that patient could have an ST elevation myocardial infarction. These patients also have elevated cardiac biomarkers like troponin and creatinine kinase, but this doesn't occur until about 4 to 6 hours after the infarction starts. The ST segments can be recognized within minutes of an infarction beginning. The different leads on the 12-lead EKG are looking at different anatomic portions of the left ventricle, and leads go together such that where the ST elevations occur in terms of leads can tell you which part of the left ventricle is having a myocardial infarction and is ischemic. So for example, in an anterior wall myocardial infarction, meaning there is ischemia of the anterior wall of the left ventricle, the leads that will display ST elevation are V1, V2, V3, and V4. And here's an example of a patient having an anterior myocardial infarction. There's ST elevation here in lead V2, V3, and V4. You can see it may be a little bit of in V1. Classic findings of an anterior wall ST elevation myocardial infarction. This type of STEMI is usually caused by occlusion of the left anterior descending artery because that's the vessel that supplies the anterior wall of the left ventricle. The leads that will show ST elevation in a lateral wall myocardial infarction are leads 1, AVL, lead V5, and V6. So here's an EKG from a patient having a lateral ST elevation myocardial infarction. You can see the ST elevations in lead 1 and AVL. You can also see them a little bit in V6 and a little bit in V5. Patients who have lateral wall myocardial infarctions usually have ischemia of the left circumflex artery because this supplies the lateral wall of the left ventricle. And then finally, the leads associated with the inferior wall of the left ventricle are leads 2, 3, and AVF. These are sometimes called the inferior leads. And so here's an EKG from a patient having an inferior wall myocardial infarction. There's ST elevation in lead 2, lead 3, and also lead AVF. Patients with inferior wall STEMIs usually have occlusion of the right coronary artery. About 80 or 90% of patients are called right dominant, and that means that the right coronary artery supplies the inferior wall. Small minority of patients, about 10% or so, are left dominant. In those patients, the circumflex supplies the inferior wall, and ST elevations in these leads can mean circumflex ischemia. There's a very rare variant of an ST elevation MI called a posterior STEMI. This occurs when there is occlusion of the posterior descending artery, which supplies the very bottom of the left ventricle, sometimes called the posterior wall of the left ventricle. Patients having a STEMI involving the posterior wall will display anterior ST depressions, not elevations, in the standard lead EKG. So if you look on the screen here, this is a patient having a posterior STEMI. This is a standard 12-lead EKG, and what we're seeing are ST depressions in leads V2 and V3 and V4. You can see that the ST segments are depressed here compared to the baseline. So if you were looking just at this normal EKG, you might not realize this is a STEMI. In order to recognize that it's a STEMI, what you have to do is place posterior leads. These are leads V7 through V9. They're not standard EKG leads. And if you do that in a patient with this type of EKG shown on the screen, you will see the ST elevations in leads V7, V8, and V9. Basically, these leads are placed around the side of the chest and onto the back. They're not necessary under normal circumstances. The only time they need to be used is when you have this type of anterior ST depression on the normal EKG and you suspect a posterior STEMI. Many posterior STEMIs are missed because providers identify the ST depressions and think there are no ST elevations and therefore it's not a STEMI. Another rare variant of an ST elevation myocardial infarction occurs when there's occlusion of the left main coronary artery. This artery branches into the left anterior descending and the left circumflex artery, and what you will see on the EKG when there's occlusion of the left main coronary artery is ST elevation in lead AVR only. Lead AVR is sometimes called the forgotten lead because it's not important in most cases of diagnosing ischemia. The one time it's important is in looking for left main occlusion. What you'll see is AVR ST elevation like shown here, and all the other leads will show T-wave inversions and ST depressions. And you can see that here. There are ST depressions in 1 and 2. You can also see T-wave inversions and ST depressions in V6 and V5. Diffuse ST depressions and T-wave inversions with ST elevation and AVR, that's a left main occlusion. Most patients with ST elevation myocardial infarction present only with chest pain, but there are some patients who present with other features that are a result of special complications of STEMI, so let's talk about those now. The first one we'll talk about is a right ventricular infarction, which is a complication of inferior ST elevation myocardial infarctions. So when we say a patient has an infarction of the anterior wall or the lateral wall or the inferior wall, we are talking about the walls of the left ventricle. But in a subset of patients with inferior STEMIs with ST elevations in 2, 3, and AVF, the right ventricle will also be affected. This means that these patients, in addition to having ischemia of the inferior wall of the left ventricle, will also have ischemia of the right ventricle. And when this happens, the patient will lose right ventricular contractility, and the loss of right ventricular contractility will lead to elevated jugular venous pressure, and therefore findings of elevated jugular venous pressure are a classic finding in patients who have a right ventricular infarction. In addition, one of the main jobs of your right ventricle is to load up the left ventricle. So when there is a loss of right ventricular contractility, there is decreased preload to the left ventricle, and that causes the cardiac output to fall, and that leads to hypotension. So elevated jugular venous pressure and hypotension are the classic combination of clinical features seen in patients who have a right ventricular infarction. Remember, these patients will always have an inferior STEMI. You don't get right ventricular infarction from anterior STEMIs. The diagnosis of a right ventricular infarction can be made by placing right-sided chest leads. If you look at this drawing on the screen, this shows where the normal chest leads are placed. Usually V1 is on the right side of the chest, and then V2 through V6 wrap around the left side of the chest. To make a diagnosis of a right ventricular infarction, you place chest leads on the right side of the chest, and those chest leads will show evidence of ST elevation, and that's how you make the diagnosis of a right ventricular infarction. Two super high yield points for your boards about right ventricular infarctions. The first one is you want to avoid nitroglycerin in these patients. Remember, they've lost their preload because of right ventricular infarction, and nitroglycerin further lowers preload by dilating the veins and pooling blood in the venous system. So these patients will get hypotensive if you administer nitroglycerin. The second thing to know is a very important element of treating right ventricular infarction is to administer IV fluids. That's because these increase the preload to the left ventricle, and that helps to overcome the loss of right ventricular contractility. Another special complication of an inferior STEMI is sinus bradycardia and heart block. When patients have inferior wall ischemia, this often leads to dysfunction of the SA node or the AV node. The right coronary artery supplies the SA node with blood in about 60% of patients, and it supplies the AV node in about 90% of patients. So when you have ischemia of the inferior wall caused by right coronary artery occlusion, patients can develop bradycardia or heart block. And then the final special complication of STEMI that you should know about is cardiogenic shock. This usually only occurs with large anterior ST elevation myocardial infarctions. These infarctions cause ischemia of a large amount of myocardium, and as a result, cardiac contractility falls and the patient becomes hypotensive. The patient will also have tachycardia because the left ventricle is not pumping, the pressures go up in the chambers of the heart, and pulmonary edema will occur, and respiratory distress can also occur. Now let's talk about the treatment of STEMI. We say that in treating STEMI, time is muscle, and what we mean by this is that a coronary artery is occluded by a thrombus in patients having a STEMI. The longer that occlusion goes on, the more heart muscle that will die. So this is a picture on the screen of a plaque. It's ruptured and there's a thrombus, and there's no flow going through this vessel. That will cause a STEMI. So the longer you let this go on, the more myocytes that will die. And in clinical studies of patients with STEMI, the longer it takes to restore blood flow through the vessel, the more likely the patient is to die from heart disease, the more likely they are to later develop heart failure symptoms, and the more future hospitalizations they will have for heart disease. These things have all been borne out in clinical studies, and therefore we consider treatment of STEMI a medical emergency. The faster you restore blood flow, the better the outcomes for the patient. So with that in mind, the main objective of treating STEMI is to open the artery. This is called revascularization. And there are two ways that this can be done. In most hospitals in the United States, the way this is done is by emergency angioplasty. There is a team on call that can take the patient for a cardiac catheterization, and catheters can be used to mechanically open the artery and then usually place a stent, and this will restore blood flow through the vessel. And according to guidelines, this should be done in less than 90 minutes. In hospitals that don't have emergency angioplasty available, a second option is thrombolysis. This involves the administration of a drug like Alteplase or TPA. These are clot-busting drugs, and the goal is to bust up this clot and restore blood flow. And according to guidelines, thrombolysis should be done in less than 30 minutes. And clinical studies have shown that emergency angioplasty is superior to thrombolysis. However, not every hospital has access to a cath lab and an emergency angioplasty team, so in those locations, thrombolysis is used. And in hospitals that treat STEMI, for each patient, they monitor the so-called door-to-balloon time or door-to-needle time. The door-to-balloon time is for hospitals that do emergency angioplasty. It's the time from when the patient enters the door to the hospital to the time when a balloon is inflated in the artery to remove the thrombus and restore blood flow. That's the door-to-balloon time. And according to guidelines, best practices are that this should be less than 90 minutes for most patients. In hospitals that don't do emergency angioplasty, the door-to-needle times monitor. This is a time from when the patient arrives in the hospital until the thrombolysis is administered. And according to guidelines, this should be under 30 minutes for most patients. And these are standard quality of care metrics in hospitals that treat patients with STEMI. The most important thing in treatment of STEMI is time. So you administer medical therapy just to support the patient while you're doing work in parallel to get the artery open. Because this problem is caused by a thrombus in a coronary artery, it's a thrombotic problem. So usually, while we're doing work to open the artery, we will simultaneously be given drugs like aspirin to inhibit platelet aggregation and heparin to inhibit clot formation. This is also an ischemic problem, and there's ongoing ischemia that can damage myocytes. So therefore, beta blockers are usually given to reduce oxygen demand, and nitrates can also be given to reduce oxygen demand. All these things are done to minimize ischemia, and they're done in parallel to getting ready and making plans to restore perfusion to the heart. A couple of caveats in the treatment of myocardial infarction. You have to be careful with beta blockers. Like we talked about before, patients with inferior STEMIs can develop bradycardia or AV block, and if they have evidence of this in their EKG, then you don't want to give a beta blocker. We also talked earlier about right ventricular infarction, and when that's present, you want to avoid nitrates, because if the patient has a right ventricular infarct, the preload is low, and the nitrates will drop the preload further, and that can cause hypotension. Some other drugs that can be used in the treatment of STEMI are shown on this slide. Clopidogrel is a platelet inhibitor that blocks ADP receptors. Eptifibatide is a 2B3A receptor blocker. It inhibits platelets. And bivalirudin is a direct thrombin inhibitor. It inhibits clot formation. The use of all these drugs is highly variable from one institution to the next, so they're not going to ask you about this in your board exams. You should just know that these are sometimes administered depending on the protocol in a particular hospital. So here's the typical course of a STEMI patient at many hospitals in the United States. The patient arrives in the emergency room with chest pain at 5:42 p.m. An EKG is done immediately on arrival and interpreted at 5:50 p.m. showing a STEMI. The cardiac cath lab is activated and prepares for emergency angioplasty. In the emergency room, supportive meds are given. These include aspirin, metoprolol, a beta blocker, a nitroglycerin drip, a heparin bolus, and then the patient is transported to the cath lab at 6:15 p.m. And then the artery is opened with a balloon angioplasty at 6:42 p.m., yielding a door-to-balloon time of 60 minutes, which is within the goal of less than 90 minutes. At a hospital that doesn't have emergency angioplasty, treatment can look like this. So the patient arrives at the ER at 5:42. The EKG done at 5:54 shows a STEMI. In the ER, the patient's given aspirin, a beta blocker, a nitro drip, and a heparin bolus. And then thrombolytics is performed with TPA given based on weight at 6:07 p.m. It's administered as an IV push, and this gives a door-to-needle time of 25 minutes, which is within the goal of less than 30 minutes. For the remainder of this video, I'm going to talk about complications of ischemia. After a patient has a myocardial infarction, either an end-STEMI or a STEMI, over the next few days and weeks, they are at risk for certain complications. Most of these complications are only seen with large STEMIs where lots of myocardium is damaged, but in theory, they can be seen with any form of myocardial infarction, even an end-STEMI. So in the first few days after a myocardial infarction, the greatest risk is arrhythmia, and we'll talk about that in a minute. Over the next 5 to 10 days, there are a number of so-called mechanical complications. These are things that happen when there's necrosis of the heart. And then several weeks later, there are a couple of rare late complications that can occur, and we'll talk about these as well. So in the first 4 days after myocardial infarction, the greatest risk is sudden cardiac death from ventricular tachycardia. This is an EKG showing ventricular tachycardia, and patients who have ischemic myocardium are at risk for developing this, and especially if it happens out of the hospital like at home, it can happen very suddenly and degenerate into cardiac arrest and death. And in fact, the most common cause of sudden cardiac death among older patients is myocardial infarction. After myocardial infarction, these patients develop ventricular tachycardia, then ventricular fibrillation, and finally cardiac arrest. And because of the risk for arrhythmia and sudden cardiac death, most patients with myocardial infarction are hospitalized for the first few days after the infarction so they can be monitored by a telemetry monitor in the hospital. In days 5 to 10 after a myocardial infarction, necrosis of the walls of the left ventricle begins to cause breakdown of those walls, especially in large myocardial infarctions like STEMIs. This can lead to a number of what are known as mechanical complications of myocardial infarction. There are 3 of these, and I've listed them all on this slide. The first mechanical complication is free wall rupture. This is where one of the walls of the left ventricle ruptures and blood leaks out. It's usually fatal and causes sudden death, although it can lead to tamponade and clinical features of tamponade. Second mechanical complication of myocardial infarction is rupture of a mitral valve papillary muscle. If this happens, it leads to acute mitral regurgitation. There could be a holosystolic murmur present. And because the regurgitation is usually sudden onset and severe, patients immediately go into heart failure and respiratory distress. And this is most common in patients who have inferior myocardial infarctions. One of the papillary muscles inserts into the inferior wall, so an inferior myocardial infarction can cause that papillary muscle to rupture, and that will cause severe mitral regurgitation. And then the final mechanical complication is a septal rupture. If the left ventricular septum between the left and right ventricle ruptures from necrosis, this leads to formation of a ventricular septal defect. This can cause a loud holosystolic murmur with a thrill. Sometimes the VSDs are so large there's no murmur and no thrill, but you can hear a murmur and a thrill in some cases. And if the VSD is large enough, there'll be lots of blood shunted from the left ventricle to the right ventricle. This will lead to hypotension and evidence of right heart failure, things like elevated jugular venous pressure and lower extremity edema. And the best test for any of these complications, if you suspect that one of these is occurring, is always a transthoracic echocardiogram. It can see the free wall, it can see the papillary muscles, it can see the ventricular septum, it can detect mitral regurgitation. This is the best test days 5 to 10 after myocardial infarction if you think one of these mechanical complications has developed. Several weeks after a myocardial infarction, patients can develop a left ventricular aneurysm. A left ventricular aneurysm occurs when a portion of the left ventricular wall is replaced by scar tissue. If you look at this drawing on the screen, this is the anterior wall of the left ventricle. Normally it has muscle tissue, but in this drawing, it's been replaced by scar tissue. That scar tissue is not going to contract because it doesn't contain myocytes, and it also can bulge outward, and that is called a left ventricular aneurysm. This almost always happens only after anterior infarctions. Large anterior STEMIs are what usually lead to a ventricular aneurysm. The danger of these aneurysms is that blood flow is sluggish in the aneurysm because there are no contracting myocytes. Therefore, thrombus can form, and if a thrombus forms in a left ventricular aneurysm, a piece of that thrombus can break off and travel and cause a stroke or a peripheral embolism. And then finally, you should know that patients who have an anterior wall left ventricular aneurysm will have persistent ST elevations on their EKG even after the ST elevation myocardial infarction has resolved. This EKG is from a patient of mine who has an anterior wall aneurysm. So the leads that look at the anterior wall are leads like V2 and V3 and V4. And if you look carefully at those leads, the ST segments are elevated. This is the baseline and this is the ST segment here, and it's elevated. So even though this patient is many months out from myocardial infarction, this patient still has ST elevations in the anterior leads, and that's what you see in patients who have had an anterior wall myocardial infarction and developed a left ventricular aneurysm. Note also that there are Q waves seen here in the anterior leads. That is also a classic finding in a patient who has had an anterior wall myocardial infarction. A very rare late complication of a myocardial infarction is a ventricular pseudoaneurysm. In a ventricular pseudoaneurysm, there's rupture of the left ventricular wall, but the rupture is contained by pericardium and scar tissue. So it's not really an aneurysm. There's no bulging outward of the endocardium or the myocardium. It's just that a break in the left ventricular wall has been contained by the pericardium and scar tissue. These are very dangerous because they can rupture. Sometimes they cause the patient to have chest pain or dyspnea. And these are almost always seen in the inferior wall. It's the opposite of true ventricular aneurysms, which usually occur in the anterior wall. Pseudoaneurysms usually occur in the inferior wall after an inferior STEMI, and they tend to occur within a couple of weeks after a myocardial infarction. True aneurysms, like we talked about in the last slide, usually don't occur for about 4 to 5 weeks, but a ventricular pseudoaneurysm can occur within the first couple of weeks. Dressler syndrome is a form of pericarditis that occurs weeks to months after large myocardial infarctions like STEMIs. These patients develop the typical symptoms of pericarditis, which I talk about in another video. So they can have chest pain, on auscultation you can hear a friction rub. This is an immune-mediated phenomena that leads to inflammation of the pericardium. The details are not understood as to why it occurs. It's a clinical diagnosis based on the presence of features of pericarditis, and the treatment is similar to other forms of pericarditis. It's treated with NSAIDs or steroids. So in a board question, this will be a patient who had a STEMI 4 or 5 weeks ago and now has typical features of pericarditis. That patient has Dressler syndrome. There is a second form of pericarditis that can occur following a STEMI that is very rare, but you should know about it for your board exams, and it's called fibrinous pericarditis. This occurs a few days after myocardial infarction. It's sometimes called post-MI pericarditis. And this is not autoimmune. This occurs because the myocardial inflammation has extended into the pericardium. Basically, the patient has had such a large myocardial infarction that there are inflammatory cells all over the walls of the left ventricle, and some of those cells have crawled into the pericardium and caused symptoms of pericarditis. This occurs a few days after MI, in contrast with Dressler's, which is a few weeks after MI. Dressler's is sometimes called post-cardiac injury pericarditis, to contrast with fibrinous pericarditis, which is sometimes called post-MI pericarditis. This is rarely life-threatening, the diagnosis is clinical, and usually there's no specific treatment other than treating the myocardial infarction, and as the left ventricle heals from the ischemic damage, the fibrinous pericarditis will go away. I'm going to finish with this slide and leave you with a general point about the evaluation of chest pain, both clinically and in your board exams. Anytime you're evaluating a patient with chest pain, you have to consider the big three diagnoses that are life-threatening and that are associated with chest pain. And those three diagnoses are STEMI, aortic dissection, and pulmonary embolism. The best first test in a patient with chest pain is always going to be an EKG to evaluate for STEMI. EKG is done at the bedside. It just takes a few minutes to perform, and it will immediately let you know whether or not the patient has a STEMI. Now, there are many other tests that are also used when evaluating chest pain, but those are done after the EKG. So, for example, CAT scans are done to evaluate for pulmonary embolism or dissection, but it takes time to get the patient to the CAT scanner, so you're going to do the EKG first. Cardiac biomarkers are done to diagnose NSTEMI, and a D-dimer is sometimes done to evaluate for pulmonary embolism, but these are lab tests which are going to take a while to come back. So you're always going to do these second, and you're going to first want to do the EKG. As soon as you're aware the patient has chest pain, that's the go-to test, the EKG. And that concludes our module on STEMI.